Good morning. Good morning. This is a busy day. Welcome to the Department of Medicine and Ground Rounds. I want to remind everybody that this institution and this department have engaged in a process of transformation over the past few years to join the more than 80% of institutions in the United States with a unified clinical practice program. And that started some years ago with single point contracting, more recently with the building of the HCOC Center, more recently with electronic record that we're still working on. And this summer, and certainly this year, all the clinical enterprises will be joining into University of Louisville Physicians, ULP, and the Department of Medicine will be joining in July. 3 departments already in, surgery, family medicine, and neurology, and is going as scheduled. But today at 9 o'clock, John Elliott, and you all received an email some weeks ago, John Elliott will be here with just a few slides for 15 minutes or so to begin discussions about pension and benefits and how that may impact you as we move from UMA into ULP. Those of you who are not in UMA don't have to worry about this. Now, it's a special day not only because we have Kerri here to give a lecture, but there are a couple of things to remind you. Back in 1967 was the first legalization of human artificial insemination. Where? In Oklahoma. Interesting enough. Number 2, reserpine became a big deal in Congress. And in fact, Dr. Nathan Klein, who was a psychiatrist doing research in reserpine and mental diseases, gave testimony in Congress about how to study these drugs and how important they could be for the future of managing psychiatric disorders. And that sort of became one of the stepping stones for the development of the Mental Health Studies Act in 1955. Edward Jenner was here. He was not here. He was born on this day back in 1749. We've told this story before. He did the vaccination for smallpox by vaccinating this child with cowpox. We've talked about this. But I want to discuss today 2 people. One is Vincent du Vignal. When you're in the ICU and giving people vasopressin, think about Dr. Vignal, an American biochemist who won the Nobel Prize in chemistry for his work with polypeptide hormones. And he actually isolated and synthesized vasopressin, among many other things. And that was back in the early 1900s. Now, the one that's more interesting to me is Joseph Leopold Auberger, and I'll finish here. Dr. Auberger, so remember him when you go and see somebody and you do this on their back. Now, this gentleman was an Austrian physician, and his father had a wine cellar, so he would tap on the barrel to find out the level of wine. And as a physician, he started using that, and he actually described the method of percussion to define what was underneath the skin and those tissues, and there was fluid or not. And he described that back in 1761 in an article published in Inventum Novum, a journal that is probably not around today. And nobody cared because nobody read this. And it wasn't until 1808 that it was published and translated in French that suddenly it started getting noticed, and the rest is history. And I'll leave you with Dr. Eleanor Lederer, who's our acting chief of the VA and division director for nephrology, to introduce our distinguished guests.
Well, I think the subject of health literacy is one that is largely ignored. We do a lot for our own self-education, education of trainees, but really don't talk much about the education of patients and how important that might be in achieving the goals of care that we want to achieve. So it is my great pleasure today to introduce our speaker, whose specialty is exactly health literacy. Kerri Cavanaugh is an assistant professor and the director of Dialysis Clinic at Vanderbilt University. She did her undergraduate training at Dartmouth. Undergraduate training at Dartmouth, went to medical school at Yale, and then did her postgraduate training at Johns Hopkins, where she was a fellow in nephrology and also received a master's in science. She has worked in the field of health literacy for a number of years now, published a number of articles, and holds 2 grants, Carl Gottschalk and is an NIH site investigator for the study of health literacy and chronic kidney disease. So it's my great pleasure to introduce Kerri.
Thank you so much, Dr. Lederer, and I really appreciate the invitation to come and meet with you this morning and speak to you about a topic that I'm very excited about. And so although I am a nephrologist and very dedicated to our patients with kidney disease, certainly health literacy is an issue that hopefully can speak to all of you, especially those clinicians and also researchers who are engaging with enrolling human subjects. So we'll get started. Stand. So we have a couple objectives for today. The first is really to get us all on the same page and to talk about the definition of health literacy, numeracy, and various ways that we can measure them, that we can assess them, primarily for research, but maybe with some hope to consider this even in clinical, more broad clinical applications. Then also to describe individual and system risk factors for low health literacy, and then its impact on health outcomes. And I'll focus mostly on diabetes and kidney disease, although we'll have a few other kind of sample populations thrown in there as well. And then lastly, we'll discuss a little bit of the growing evidence for improvement in health outcomes by trying to address this area of health literacy. So this is kind of a visual representation of sometimes the disconnect between how we're trying to reach our patients and what mechanisms we're using to do that. So often, especially in the United States, but we could say that this is worldwide, that one way to think about this is not solely to focus on individual people's skills, but rather that it's the combination and the intersection between the demands and complexity of the system, and in particular the healthcare system, and we all know what that means. Various buildings, just finding locations of clinics sometimes is challenging for ourselves as well as our patients. And this intersection with the skills and abilities of a very heterogeneous and diverse population across a variety of disease conditions and content areas. And so health literacy is really visually this. And it's not so much that we're trying to modify totally this, we might a little bit, but really we're trying to reduce the demands and complexities of the things that we do so that we're more in line. So let's step right into sort of differentiating some of the different definitions between literacy and then going on to health literacy and numeracy. So literacy, interestingly, is actually defined, and it's defined by law, actually. So there was a law passed in 1991 that is the definition of literacy, at least in the United States. And it states the ability to read, write, and speak in English and compute and solve problems at levels of proficiency necessary to function on the job, in society, to achieve one's goals and develop one's knowledge and potential. So several aspects to this, obviously a very broad construct, and I'll break that down for you in a minute, some of the components. But the fact that it does focus on English, which we all know that there's a variety of debates in how that applies to, again, our heterogeneous and particularly at-risk populations. So the Institute of Medicine created this relatively nice schematic to illustrate the components of literacy. Again, to target that broad definition and broad outcome. And we think sometimes literacy, people automatically equate it to really only reading and writing or print literacy, but it's much more than that. It really has multiple domains. It's paired with oral literacy, so people's skills and their abilities related to listening and speaking, but also numeracy, and that's very dear to our medical hearts. Think about all the numbers that we ourselves calculate and then try and translate and communicate to our patients, particularly in nephrology. And then, of course, this is all on the background of people's perceptions, interpretations, cultural exposures, and then their general knowledge base. So in the late 1900s, early 2000s, actually, there was a very large national sampling performed of a representative U.S.-based population where they measured literacy, numeracy, health literacy, etc. This was called the National Assessment of Adult Literacy, and it's available online. And this is essentially a breakdown of their categories. And we're not going to get into too much detail, but they broke it into 4 categories: below basic, basic, intermediate, and proficient. And this is as it relates to prose skills or reading. And below basic skill sets are those that an individual has very simple, it's only able to tackle very simple tasks, concrete skills. Basic is really just everyday activities. And then above that is intermediate, more advanced literacy activities, and proficient, complex and challenging things. And these were the results. These were their findings. Again, this was representative, people aged 16 and above, and this did not include those who were truly functionally illiterate. And this was the breakdown. And surprisingly, a fair amount, if you combine these below basic and basic categories, were considered to have low literacy levels or limited literacy. And in raw numbers, this is somewhere in the neighborhood of 80 to 90 million people. So in the U.S., this is not an insignificant population. Another perspective to think about is if only 12% reach the proficient level, we have 88% that are less than proficient. So it sort of depends on your frame of reference and what task there is. But there are challenges for individual skill levels related to literacy. And it's projected to be something that will only increase over time, actually. This is a diagram of the 1992 assessment right here. And people who fall under the curve in these lower levels are those that have challenges related to literacy skills. And this line is a projection for 2030. And this is because it follows educational patterns, immigration patterns, and other things that relate to literacy, which are not going to be surprising to you. So it may be even a greater portion of our population that this is affecting and that you'll be interacting with. So numeracy, or quantitative information, is actually even more common. So this is the breakdown for the literacy, or the reading. And using the same type of categories, numeracy has an even greater burden of lower limited numeracy skills, whereas 22% were in the below basic and 33% in the basic categories for about 110 million people. And they don't always go together. So and in that you may have somebody who has usually excellent literacy skills or higher literacy skills, but may have very low numeracy skills. So this was a sample of about 200 patients in our own primary care clinic, characterizing these into categories equivalent to less than 9th grade equivalent skills or greater than 9th grade. And again, we have some fair proportion in the low cell and the high cell. Very few who have high numeracy but low literacy, but a fairly good proportion that may have good reading skills but poor numeracy skills. So health literacy is a little bit of a nuance on literacy itself. It's obviously related to health, and it's defined as the degree to which individuals can obtain, process, understand, and communicate about health-related information needed to make informed health decisions. So again, a very functional application of all of those various activities that break down under literacy. Back to the now assessment to give us some idea of, again, reinforcing the proportion of people who are in our at-risk populations. These are their graphs by 2 demographic factors, age and race. And the dark purple box is that below basic category, and the white box being the basic, and we'll focus on those. And then these are different age categories, so younger to higher, and this is the group that's 65 and above. And what you'll notice is in the patients we're likely intersecting the most with, these are also probably the most at risk for having challenges and limited literacy skills. So we're up to the neighborhood of 55% in the older age group falling into these skill categories. And if we look at race, we also see vulnerable populations echoing socioeconomic status, education, and English language proficiency. And what we have here again is the purple box, and this really big one, 41% is Hispanic, and then larger ones Black, and American Indian, and Native. So again, particularly in those with multiple chronic kidney disease conditions, diabetes, hypertension, kidney disease, heart failure, our at-risk vulnerable patients that we already know are vulnerable may have that much more of a challenge if we include thinking about communication skills related to literacy. So this was an article, a clinical discussion by Michael Pashorlau, who's at Boston University and one of the leaders in the health literacy field. And he created this schematic to again, further emphasize that it's not only individuals' skill sets that contribute to health literacy and risk factors for health literacy, individual characteristics, again, like age, or rather race, English language proficiency, employment, etc., cognitive function. But it's also the contextual factors of the system that contribute to this intersection. And really, health professionals' interactional skills and the complexities of the individual's clinical condition and how healthcare professionals treat that and really are cognizant of their actions related to individuals plays an important role ultimately in this construct of health literacy. So it's really us. It's onerous. It really is on us again to reduce that error, to reduce those demands and complexities, and really think about how it is that we engage and connect and speak and dialogue with our patients. All right, and it's just to finish up that numeracy too has a definition. There's one sort of simple one from one of my mentors at Vanderbilt, and he defined it as the ability to use numbers in daily life. Pretty straightforward. And there's been a more involved one. You know, we are academics, and there's been a more involved definition promoted that you almost need a higher degree of literacy to read, but degree to which individuals have capacity to assess, process, interpret, communicate, act on numerical, graphical, chronicle, by statistical, and probabilistic health information to make health decisions. And I think all this really speaks to is how much of what we do as clinicians when communicating about patients is quantitative. When we're trying at all to think about shared decision making, if we're focusing on patient-centered care, shared decision making, we're trying to engage patients in risk decisions to weigh uncertainty about medications, about outcomes. This becomes very challenging for ourselves, not just our patients. All right, so we know what this is, but how do we get at it? I think we all kind of have a gut instinct sense about it, but there are relatively rigorous methodology to measure it. And in the research arena, there's been two validated measures, and I'll share you with them here. The first is called the Test of Functional Health Literacy in Adults. And both of these measures have been validated against typical reading or aggressive reading, educational type scales. And this short test, there's a couple versions, but it's a 7-minute timed test. And it looks like this, where you have two passages where it reads a medical statement and you have to pick the word that makes the most sense to fill in there. The second is a pronunciation test. So it's the Rapid Estimate of Adult Literacy in Medicine called the REALM. This is what it looks like. There's 66 words, starts at FAT and goes to impetigo. And the person just has to pronounce them. They actually don't have to define them. But still has pretty good psychometric relationships with other measures. The advantage to it is it's pretty fast, less than 3 minutes to administer. But still, neither are really likely appropriate for clinical applications, but they're really the most widely used in research. Here's another one that's out there called the Newest Vital Sign. It's based on a food label, so they're presented with a food label, and then it has several questions sort of interpreting the food label. And although this had some excitement because it seemed more practical, it really hasn't been used very much. Extending beyond this, there have been promotion recently for several screening questions. So they're questions that are relatively simple to administer. This is the first. How confident are you filling out medical forms by yourself? It really gets at subjective health literacy, so it's asking people their confidence with accomplishing something rather than getting at their objective skill set. So sometimes that's a little bit easier for patients in particular to address. And this is the measures that they respond to. And these showed very good relationships with those two other health literacy surveys that I showed you. And so there's a lot of excitement about these questions because, again, they're short, they're relatively easy to administer, and there's a lot of interest about whether or not we could use these as, again, screeners to identify more at-risk populations, more at-risk patients. And we have a very large ongoing study at Vanderbilt right now with one of my colleagues who's measuring this on about 3,000 inpatient heart failure patients, and then has measured it in almost 10,000 outpatients. So we're really eager to see if it helps us in any way. As far as numeracy, there are several kind of categories under numeracy as well. Something we call general numeracy, and this is kind of what you would think about: calculations, applied numeracy, adding, subtracting, understanding ranges, etc. More complicated likely is risk communication, fractions, probability, statistics, etc. The TOEFL itself, the long version, does have a numeracy component. It's based on prompts where they look like food labels, and not food labels, rather medication labels, and ask the patients to kind of go through the labels and interpret those. And then we also have some disease-specific numeracy tests, and in particular one in diabetes that I'll share with you. And the idea being that if we're getting closer to the knowledge content of the disease, maybe we're more applied and closely to what's happening patient in their day-to-day care related to their care of their disease. So again, in research, what we've administered is what's called the wide range achievement test, and this is what it looks like. It's typical kind of intimidating math test. Has 40 questions, it's timed, no calculator, starts at 1 + 1, but can get pretty complicated. It makes people sweat and definitely not something for clinical applications. There's also a subjective numeracy. Like those screening items, those 3 questions, there are a subjective scale that has pretty good performance. So you can ask someone, how good are you at working with fractions? How good are you at working with percentages? And if people are acknowledging that they're not so good, that might be a signal that we have to figure out how to engage with them better. And although this is 8 questions, our group has proposed using 4 of these questions in combination with the 3 literacy screeners, and that works pretty good too. So we're trying to whittle it down to make it as few questions as possible, but yet remain informative. This is an example from the TOEFL of what an applied question might look like. So normal blood sugar, they're given a prompt, normal blood sugar is 60 to 150. Your blood sugar today is 160. Seems pretty straightforward. If this were your score, would your blood sugar be normal? So it gives you a definition and asks you to interpret this number relative to the range. This was a study of over 3,000 Medicare patients. And what we've got broken down here is the total, and then by literacy level. So inadequate, which is less than 6th grade level, marginal 7th to 8th grade, and adequate greater than 9th grade reading levels. And I show you the proportion of people who incorrectly answered this question. So of the total population, 36% answered it incorrectly, but in the inadequate group, 67% answered it incorrectly. I mean, that's more than 50-50, and it's a yes-no question. So even something that we may think is relatively straightforward might not be so much for some of the patients that we're engaging with, and we really have to remind ourselves, especially in the busyness, that we get caught up in the day-to-day in our clinic. Also, we need to recognize and remember that there is a significant stigma related to limited reading skills. And so there's several different studies. This is only just one example to remind us that people don't like to admit that they have problems reading. And there's often, if you ask someone overtly about interpreting medication labels or schedules or anything, often you'll get a lot of kind of excuses. So something about vision, forgot my glasses. There's a lot of other prescribed responses, and it's really on us to dig a little bit deeper to try and identify if there are barriers that we're missing, especially related to literacy. So why bother? So I've showed you some measures. We defined it. Why is this even important? Do we really care about this? Again, we have lots of other things to tackle. This is one model of how we might think about where literacy, which is in the middle here, might intersect with the care of our patients. This is promoted by David Baker from Northwestern. And where we think this may intersect is that if you have better health literacy skills, or if you have lower ones, this will affect your ability to attain new knowledge, might affect your attitudes towards your health condition, affect your self-efficacy or your confidence in carrying out the tasks related to your conditions, and ultimately your behavior. And then those would be the intermediaries to improving health outcomes. There have been a lot of studies looking at health literacy in a variety of health conditions, and there's been 2 very large reviews, one published last year in the Annals of Internal Medicine, summarizing all of the different studies. And it really cross-sections across, again, various health outcomes, health services, conditions, behaviors, and again, knowledge. So I'll just emphasize here there's been a lot of work in this to show that it's present and related across disciplines. And so why don't we cut to the chase? We'll forget those middle behavior stuff. We'll just get right to the hard outcome. Everyone wants to know about hard outcome and effect on hard outcome. So of course, while we're not randomizing people, but we have several observational studies that do suggest a strong relationship between health literacy and mortality. This is one of the first, again, by Dr. Baker, 3,000 patients, age 65 and above, mostly white, but they were followed for 6 years from 4 different centers. And what you have across here is the follow-up time in months, and again, sort of the Kaplan-Meier curves over time. And this little dotted line is the inadequate health literacy, and this is high is the adequate. So we have this nice dose response, so to speak, over time of the relationship between health literacy and mortality. We also examined this in a cohort, an incident cohort of chronic dialysis patients. So almost 500 patients who are initiating dialysis. So kind of the sickest of the sick generally in terms of our patients. And this was our prevalence. Again, that most people had adequate literacy level, 68% in this group, but there was almost 30%, 32% had either marginal or inadequate literacy. We used the RELM, that word pronunciation test, to characterize these folks. And we went on to follow these people for 2.5 years after the start of their dialysis time. And we too found a very similar relationship to what I just showed you with Dr. Baker, in that those with we dichotomized it to greater than 9th grade or less than 9th grade, but we saw this, again, nice display over time, that identifying low health literacy at the start did predict risk over time. Again, the mechanisms in between are not described, but there was an association, and we went on to adjust for other factors related to mortality in dialysis patients, and the effect of health literacy persisted even after adjustment for these factors. And then even more recently, in JAMA last year, those health screener items. So maybe we're not going to measure the RELM, we're not going to measure the TOFLA in our practice, but we might think about doing those screener items. And what this group did, and this is from Denver, they looked at a couple thousand patients with heart failure. And so these were chronic heart failure patients, and they asked those screening items and then summed them and split them into low and high levels. And they too found relationships that were significant over time with both mortality and hospitalization. So there's something about this construct, again, as identifying a high-risk population. In addition to thinking about mortality, I just show you this one study that there is a growing interest. I suggested to you at the beginning that health literacy is often associated with our more vulnerable populations. So when we think about disparities, in particular disparities related to race, maybe there are other factors, other confounding factors, such as health literacy, that may explain some of the observed racial disparities in various things. This is one study, again, done by one of my colleagues, in 204 patients with HIV, and they were looking at medication adherence as their outcome, I believe a self-reported measure. And I just show you here when they did their first model looking at predictors of medication adherence, race, meaning non-white compared, actually this is black compared to white, showed an increased risk of non-adherence to medication by race, a magnitude of 2.4 odds ratio compared to white. However, when they added in health literacy as a measure, this relationship, although the point estimate still was above 1, was no longer statistically significant, whereas the health literacy variable was strongly associated with non-adherence. And I don't show it here, but we have also performed some disparities related work looking at A1C control, disparities by race, and we too found that health literacy and numeracy explain some of the observed difference in disparities. So maybe this might get at some of those constructs. All right, so we're in a medical school here, and of course it's kidney related. 2 kidneys. How many does he have now? Anyone? Even medical students sometimes have to repeat. Okay. So what about numeracy? There's a lot of debate in the health literacy world that we shouldn't measure numeracy, that we don't care about numeracy, that literacy is sort of that cognitive variable, and there's no value to separating out people's skill sets related to numeracy. But we're a biased group, and of course all us chemists in the audience are partial to numbers, so we're going to advocate our platform of numeracy. All right, so numeracy and obesity. We did, again, a primary care study cross-sectionally looking at numeracy, which was that math test. and looking at BMI actually, and found again a statistically significant relationship that persisted after adjustment. Cross-sectional, just an association, not causal. But we had several other works that went on to show that numeracy was related to patients' a portion size estimation and then serving size understanding and food label reading as well. So what about diabetes? Seems pretty intuitive. Numeracy skills needed in diabetes to monitor glucose, to count carbohydrates, titrate medications, including insulin, possibly pump adjustment, etc. Very quantitative. So based on this, our group went on to develop a test that combined, again, knowledge and numeracy skills specific to diabetes, covered many diabetes-related domains, and then many of the domains of numeracy. The original version of the scale, which I'll show you the results, 43 items, totally not practical for any kind of clinical use, although we're currently using a 6-item version in an R18 funded trial looking at diabetes interventions in our federal health centers in Middle Tennessee, so there's hope maybe. Lots of, again, domains, no time limits. It had good reliability. And we went on to measure diabetes-related numeracy as well as numeracy and literacy in about 400 patients with diabetes, half enrolled from primary care, half enrolled from endocrine clinics. And what I'll show you here is just our final table. It's available at Annals of Internal Medicine that did demonstrate that the diabetes-specific numeracy score was significantly related to A1C. Again, cross-sectional, but interesting, particularly as a way to identify where we can target improving our communication and instructions related to diabetes. So what can we do? So there is, again, a growing interest and emphasis on this. On the national level, the M.H.S. put together last year a national action plan. I'm sorry, I seem to have left off the website, but there's a website where you can download this action plan, and there's actually 7 goals. I just show you 2 here. I just want to emphasize that, again, there's essentially more work that needs to be done in this area, but it's being recognized as an important way, excuse me, that we may be able to further improve our health system and care of our patients. And there are some additional tools available online, again, federally sponsored by ARC. This is called the Health Literacy Universal Precautions Toolkit. And it is a very detailed and in-depth set of tools that has templates and forms and instructions for focus groups to self-assess your center. And so this is a wonderful resource and available to anyone for its use. So why it might be important to think about this. Another way to think about health literacy is that, again, those vulnerable populations may benefit the most from our comprehensive interventions. So this was a diabetes kind of case management comprehensive study, and it's broken down by the group with low literacy and the group with higher literacy. And what you see here is that in the higher group, the intervention, which again was comprehensive, multidisciplinary, had lots of components to it, didn't have much of a difference with the control group. But in the lower literacy group, the intervention had a significant improvement in A1C control over time. So again, connecting with, in particular, that at-risk group may have really significant relevance for important outcomes. So ways that we can think about getting towards this is really general approaches to clear communication. And some of these things we won't emphasize further, but really trying to get at patients' baseline understanding, so what they understand currently about their disease condition, using plain language and avoiding medical jargon. This becomes a very difficult task for us. We spend a decade or more learning how to speak to each other in a very complicated lexicon, and then it becomes, we have to sort of dial it down and change gears when we're in that clinic and talking to patients and their families, and it's not as easy as you might think. Emphasize a few key points and then repeat them, where adults and adult learners do best with repetition. Encourage patients to ask questions, and then confirm understanding. They call this kind of closing the loop using the teach-back techniques. So when you're delivering instructions to someone, again, put the onus back on yourself and go through the exercise of asking them to say back to you what you've asked them to understand or what to do, and then go through the cycle and make corrections. The original person that promoted this technique, Dean Schellinger, never really thought about the technique as something that you would kind of get caught in this cycle in clinic. Sometimes I think practitioners may not want to go there because they might be concerned it will be too time consuming. And you may not remediate completely within that clinic setting, but again, you may identify someone who's at risk and may benefit from connecting with one of your other part of your multidisciplinary team if available. So don't be scared off by the teach back loop, closing the loop. All right, write down some important instructions if appropriate and provide useful educational materials. And of course, that's a very qualified term there. This is just one study, and this is common in our materials that are out there, looking at the readability level. And this is diabetes materials from the ADA, and then I believe some were from the AHA. And while many were good, so less than 6th grade reading levels, there were a number that were 7th grade, 8th grade, 9th grade, even up to 12th grade. And the general recommendations to shoot for somewhere in the 6th to 8th grade reading level. Those of you who are participating in active human subjects research or consenting patients for procedures, your institution and your IRB may want you to get down to a 6th grade reading level, which sometimes is not that easy. But it's very important still the same. I want to share with you some of the materials that we've tested in the diabetes intervention. And again, these also are available on our DRTC website. The entire module booklet is available. We call this the ABCs and 1, 2, 3s of diabetes care. The intent of these resources were to facilitate diabetes education and self-management. They were to be used cooperatively between patients and providers. Could be used for type 1 or type 2, and they could cover either oral medications or insulin. And we had 26 different modules available. It's again been dialed down a little bit into more brochure scale, but there are some very detailed ones available free for use if desired. And again, they're intended to be customized for each patient, and there's covered areas of blood glucose monitoring, exercise, foot care, nutritional management, and medications, and had a variety of tools for logbooks and worksheets, etc. This is an example of some of what we tried to aim at in the specific content. So this is just the introductory page and kind of what it looks like, bulleted points, simple diagrams, keeping the text at the 5th to 6th grade reading level. We also use color coding to highlight certain areas. Again, this is monitoring blood sugar, able to customize for patients individual scores, explanatory bullets. This is again, use of pictures. This is a diagram of a plate method to help assist with nutrition and dietary management, one strategy. And then instructions, step-by-step instructions to do things like educating patients about how to tackle reading a food label with particular focus on carbohydrates. And then this is an example of a simplified medication instructions, so trying to, again, orient to their particular situation, and then you could fill in this sliding scale. So instead of giving instructions where you have somebody go back to adjust so many units if your blood sugar is in this range, rather just writing it out more specifically. And then again, practice skills. So you may have we have the educational part of it, the food label for an example, and then practicing, so exercises for our novice patient learners. We went on to use these materials in a randomized trial and two concurrent randomized trials at 2 centers, at Vanderbilt as well as at UNC. And we looked at, in the intervention group, use of those materials, that toolkit that I just shared with you, and its effect versus usual diabetes patient education materials. One thing to be said, this was enhanced diabetes care. All these participants had several nurse practitioner CDE visits as well as dietitian CDE visits, and continued to receive usual care from their physician or their either primary care or endocrine physician. In the intervention group, the providers also participated in some clerical health communication training exercises. And this was our essentially a summary of the combined results. And what I'll point out here, and we were looking at A1C as our outcome. And so what we saw at 3 months, so the study ran for 3 months, and then we passively followed people for another 3 months. And at 3 months, the intervention group had better improvement in A1C, -1.5, whereas the control group was 0.8. However, 3 months later, the difference had gone away, essentially, where the intervention was now only improved by about 1% and the other by 0.9. So suggests that while it may be effective while we're in it, we did counts for interactions, etc., we may need to continually reinforce or booster, in particular, at-risk patients. We did see differences in changes in self-efficacy as well as satisfaction with care in both groups, a little bit better in the self-efficacy in the intervention group. So our conclusions were that compared to usual enhanced diabetes education and management, addressing literacy and numeracy modestly improved glycemic control, and that we probably need some additional supportive strategies to achieve persistent control. So what about some of these other, so we've talked about sort of print literacy and also a little bit about numeracy. I also want to highlight oral literacy. Again, this is what we do. This is how we communicate with patients. It's very verbal demand. So we went ahead in another small study. This is 50 of our 100 primary care patient provider visits. These are mostly resident visits, although some a few attendings were mixed in there. And this was in established diabetes patients being seen in primary care. And we audio recorded their visit. So we audio recorded the entire visit and then detailed each statement that was made by both patients and providers. And we coded them about the level of complexity related to quantitative information, because that was the focus that we were interested in. And these were the categories that we split them up to. Sort of basic statements, which we think most people would be able to interpret. More intermediate statements, and then advanced, being things like risk communication, probability, frequencies, etc. And this was our breakdown by patients and providers. And you'll see that it's not as unexpected that most were basic, some more advanced, but that the providers had more advanced statements than the patients. And if we create a scoring system to be able to overall quantify the distribution of statements per provider, including the basic, intermediate, and advanced, divided by the total number of statements, what we find is that providers, not surprisingly, tend to have much more advanced and statistically significantly advanced, more frequent complexity of statements. So as hard as we try, we probably still need to do a little bit better. So as an organization, it's also something that addressing health literacy is not, again, us as individuals necessarily. Again, we need to take responsibility. However, it's really a cultural approach as an organization that can further and push this field forward. And some of the things that an organization can do are to promote productive interactions. So identifying people who are invested and identifying champions of this issue, you can go on and approach with universal precautions, so something like that AHRQ toolkit, make that available to providers in different clinics, different settings, to work with providers for continuing CME related specifically to communication skills, to develop communication technology platforms. So I didn't talk too much today about information technology, use of the web, to use of mobile devices, those kind of things. There's a developing interest in area of utilization of those. There's some caution, of course, related to the digital divide, so that certain subsets, particularly older patients or those with some socioeconomic challenges, may not have access to these, although that likely will change over time. And then addressing it, the organization itself of the healthcare, to prioritize patient-centered care, and again to streamline, simplify, standardize, and possibly even move on to providing incentives of some sort or reinforcement for quality. But it has to be a philosophy. We have to create a culture. We have to have buy-in and invest in this construct and in this concept to improve and to move it forward. So I guess we'll finish a little bit early, enough time for questions. So really our take-home points in summary are that literacy and numeracy are common and significantly associated with varied health outcomes. Addressing literacy and numeracy may not only impact patient knowledge, behaviors, outcomes, but also might be an important consideration when eliminating health disparities. and that clear communication principles, especially when exchanging complicated health information, are really fundamental to optimizing our healthcare encounters. So I have lots of people to thank in nephrology, as well as health services research, as well as my funding agencies. And I'd be happy to take any questions, open some discussion.
So I was very excited about this talk. You delivered this very nicely in a very nice, gentle way, but the impact, I want the audience to think a little bit about the impact of what you just said. Two things, two comments, and then one question. Number one, you have taken a subjective area by many and quantified it, made it into a research enterprise, moved it into evaluated interventions, identified outcomes that are important for us, from mortality to healthcare delivery in a hypothesis-driven way, describing to people that there's anything in health that we can actually develop good research that actually impacts our patients. So congratulations to you for doing that. Number two, what was interesting to me is that all the studies you presented were very consistent that 30% of our population at least have inadequate levels of literacy and numeracy. And I would actually extend this, that this goes beyond the care of your individual patient with diabetes or hypertension, that actually it's about literacy, about healthcare in general. And the decision about how people think about this institution or even merger was very much decided on the health literacy of this community. I mean, this is how important this area is. It goes beyond whether your blood pressure is okay or not. It is about whether people understand what health is about. And I thought that was really exciting. So the question for you is, I guess one concern I have is that we now have less time to help people improve their literacy. You know, are there data suggesting that improving literacy in one specific aspect can improve literacy in another aspect? In other words, if I improve literacy in control of diabetes, and then I test literacy in control of congestive heart failure, is that patient now better capable of doing that?
And of course, the answer is we don't know, and there's more
Next
work
question.
in that area. No, but you ask an important fundamental question, and there's debate in this field, and I only present to you, this is an adult venue. We are probably mostly adult care providers. There is some research about this construct in pediatric populations and surrogate caregivers, so you measure the literacy of parents or caregivers and how that relates to the care of another individual, which is a whole other body of data. But although we talk about health literacy as this very broad, applied factor, there is no real evidence about whether or not health literacy, as we define it, if it changes over time. So there aren't sequential measures of it, and then if you change it over time, does that impact health outcomes? But rather it's been utilized as sort of, again, a risk factor, sort of a descriptive factor of somebody, and then looking at interceding in terms of communication skills, demand skills, possibly knowledge skills. And so are there other studies that look at, say, improving diabetes knowledge, or improving kidney knowledge, which I'll speak tomorrow about at the nephrology grand rounds? Does that impact disease-related outcomes? Yes, I think we have evidence for that. But whether there's crossover to care of other comorbid conditions, I don't know of any comprehensive research that describes that, but it's an excellent question, because some of the things I think about, and again, we have a very small study about if there's too much demand on patients. We think about all our demands and all of the litany of lists we have to check as we're going through, especially as primary care providers. But the patients are kind of going through that same thing in their day-to-day about how do I decide what I'm going to eat, what medicines I'm taking when, how I'm going to interact with my family, how I'm going to improve my quality of life. They too have that in their face every day. So I have one small study, and I'll share the details tomorrow, that looks at whether your awareness of having kidney disease on top of diabetes and hypertension confers any improved self-care and then improvement in A1C, so improvement in diabetes. So if you know you have kidney disease, does it somehow motivate you to care for your diabetes more optimally? And it turns out in the higher literacy group, doesn't really matter. In the low literacy group, if you know you've got kidney disease, you've got kidney disease and you know it, you have worse diabetes control, you have lower self-efficacy, you can do your diabetes care, you have worse behaviors. So it's almost like information overload in some way. And so my hypothesis, and again, no data here, but is that we may inform people, but then if we don't equip them with either the tools and or emotional support to care for their condition in the day-to-day, we've done them a disservice probably. So it really, health literacy is the comprehensive approach, and attacking one piece probably isn't enough.
Good.
Thank you very much for your presentation. Along the same lines, attacking one piece of this isn't enough. Obviously, I think your research has uncovered a huge deficiency in our educational system in the United States. And has there been any link to this problem and any awareness that it's raised toward legislators or policymakers that there might be a link between the poor education of our society and poor health outcomes, and that's why we're in such a health crisis?
Yeah, absolutely, and that's an extremely important point to emphasize that, I've focused mostly on adults because that's what we care for here, but we're sort of picking up the pieces. And could we intercede earlier, much earlier? And so absolutely. And so part of that National Health Action Plan for health literacy incorporates strategies to try and get at earlier into the educational system with a focus on, improved health strategy education. It's not my personal field of research, so I can't speak really intelligently about it, except to say that it is acknowledged that this is tightly correlated with general education.
Dr. Kalin?
Have you looked at health literacy in your people who are your support staff? Your medical assistants, your TAs?
You don't have to answer that.
It's an excellent question. It's an excellent question. So there actually is, yeah.
Do they fall into reasonable levels, or are we asking people who are somewhat deficient to help us in caring for patients, which is asking blind people to help people see?
Yeah, it's an excellent question. Again, there is a body of literature about the skill sets of providers. Most have been around nursing because there's a lot of quantitative information about deficiencies, unfortunately, in some populations of nursing staff, because they're asked to mix medications and dose IVs and things like that. And so there are challenges that have been identified. Systematically, do we evaluate this? We haven't, and I haven't evaluated personally in our study, in our small studies, but it is an excellent recognition point. There are there's some brief literature looking at physicians' comfort level, so subjective assessments of dialoguing about risk communication, probabilities, interpreting statistics, number needed to treat, those kind of things, which we know are not the most simple. The simple ideas anyways, and so there is noted problems there. So some of it is that we as the provider are not equipped as well to be able to confidently deliver that boilerplate about what does this mean, how do I talk about the risk of a statin in this patient, use of the statin versus the benefit, and now I have a genetic test that gives me even more information, how do I dialogue with them about that?
Last question.
Yeah, I certainly really believe in the idea that you're talking about. And you mentioned asthma as an area. I know there are a number of studies in COPD where this sort of approach is beneficial. Having said that, the recent study this week in Analyst Internal Medicine, an all-page center PA study that really focused on health literacy and education. And they had to close that study down early because those patients actually get worse than usual care. So are there examples outside of that where maybe information given to patients are detrimental?
Yeah, you bring up an excellent point. There's a wonderful editorial along with that too, because we often think that behavioral educational interventions have no risk. And so there's a nice editorial that talks about that we need more equipoise when we approach some of these things, that what we might think is benign may confer a risk, and we just don't know. So it brings up a really nice research point as well. I think my little study I just talked to you about maybe gets at that too. You know, we don't, whether it's the intervention itself, whether it's that we're leaving a gap in our strategy, so we're not equipping somebody with the technical expertise, the skill set, the you know, maybe we have a deficiency there, that some of these concepts are very broad, and so it's hard to drill it down to one or two things. And when we do, and we focus in because of our, you know, our draw to have this very quantitative one line that somehow summarizes everything, we probably fall short and leave some things there. So more work needs to be done to understand this and to work through some of the research design and descriptive measures and how we analyze and interpret it. I think about, you know, I often think about health literacy is so broad. It's relatively new. It's really only been studied for maybe, you know, since early 2000s. And we just have more to learn and to describe and to define as an entity. You know, the Krebs cycle wasn't, you know, identified all in one, you know, in one stretch. You know, it covers a door, all the pathways that intersect the web of science. And so I think it applies here.
Thank you so much. That was outstanding.
If you're UMA, please stay for another few minutes. Brian Cavanaugh is out there. John Elliott, who's the head of Human Resources at UOP, is out there. They're going to have a small presentation with opportunities for questions about benefits and pensions and so forth. So I assume all of you that are standing up are just getting your copy.